So I wanted to talk about the Ebola virus today because it's extremely topical and it's a problem which is still going on. I wanted to start off with just two things, the first of which is to dedicate this lecture to the local UK and international staff who are battling Ebola virus in Sierra Leone at the moment. It's a difficult job, and it's, for those who are in direct patient contact, also a very dangerous job. And over 340 people have already died in the wider region among the healthcare workers who've done this. And I think we all owe them a debt of gratitude. For reasons we'll come on to, the reason I think we will get on top of this epidemic is because of the hard work and dedication of those people. The second thing I wanted to do, for those who watch this online, is to make clear that the science and the epidemiology for this is changing every week. So what I'm doing is I'm giving a snapshot of the Ebola epidemic in the middle of December 2014. Clearly, it has changed over the last few weeks, and it will definitely change over the next few weeks. This is probably the largest and most serious infectious disease public health problem since the emergence of HIV in the 1980s as a major problem in Africa. I've given here three quotations from world leaders, both in health. So the Director General of the WHO, Margaret Chan, who described this as the largest, most complex and most severe outbreak we'd ever seen. Our own Prime Minister, who said accurately this is the biggest new health problem facing the world in a generation since HIV. And also, and I think importantly, from the Secretary General of the United Nations, who said that Ebola has gone beyond health issues, and I'll come back to this. It's gone to social and economic situations, and it may even affect political stability. So this infection, it goes beyond the narrowly medical sphere. It is currently one of the major challenges for us as a globe, and indeed, I would argue, probably for us as a generation. The extraordinary thing about this, therefore, is that this started almost exactly a year ago with one child catching Ebola, who then passed it on to his family. So this major impact is 1 year on from one child catching it. In December, this child, aged 2, caught it, probably from something related to bats, either bat droppings or touching a dead bat. That's the most likely thing, we'll never know. And he passed it on, and I'll come on to some of the early epidemics. By the time we get to now, a year onwards, there have been almost 18,000 reported cases, and the unreported cases are undoubtedly significantly more than that, with over 6,000 deaths to date. And the numbers, at least in Sierra Leone, are still increasing. This talk will therefore address why this happened and, probably more importantly, what we can do about it. Now, a little bit of background about Ebola, and Professor Cox talked about the fact that actually, until pretty recently, this would not have been a subject of enormous importance, even in tropical medicine, because the epidemics we've had so far have been small and time-limited. Ebola was first recognised in 1976. It doesn't mean that's when it first emerged. Almost certainly, Ebola epidemics had been happening in the areas, the jungle areas of, for example, what was then Zaire, for a very long time. But this was the first episode that was actually recognised. And it occurred in a mission hospital, and the index case on that occasion was a teacher. And he arrived, and following him, a whole series of cases of a new disease, which involved hemorrhage, not every case hemorrhages, occurred with a mortality rate of over 90%. This was clearly a new infection, and it was clearly very serious. It was then investigated by a group of very able scientists from Zaire itself, from Belgium, Peter Piot, who's director of the London School of Hygiene and Tropical Medicine, and from the US CDC, amongst others. And relatively rapidly, really, given that this was a new infection, they identified a new virus, a filovirus, and they named it Ebola after a local river. Most people, despite the fact it only has one page in the Manson tropical textbook, as Professor Cox said at the beginning, actually most people had heard of Ebola before this outbreak, unlike many other tropical diseases, because it entered public imagination. I've just identified two of the many things which have come out in the popular literature, some of which are science, some of which are semi-science, and some of which are essentially fiction. But Ebola has become a symbol of a dangerous tropical disease that could threaten the world. So a lot of people know about it. This has actually not always been helpful for reasons I will come on to, and has led, I think, to some of the rather exaggerated reactions in some parts of the world to this very serious infection. Now, it's important to understand, before I go into the science of this, to understand that Ebola is a disease of individuals, is a disease of health systems, but it is also a disease of panic. And I'm just going to illustrate this with a couple of points, the first of which is from the World Bank. The Ebola epidemic is crippling the economies of the three major affected countries in West Africa, so Liberia, Sierra Leone, and Guinea. And I'd like to compare this, for example, to SARS, which was the last significant outbreak, which occurred from a relatively new infection. That is estimated to have wiped around $40 billion off the world economy for an infection that killed less than 1,000 people. So infectious diseases, because of the panic they engender, can actually lead to an impact on society and on economies way out of proportion to their direct medical implications. And I just compare that to the roughly 100,000 people a year who die of smoking-related diseases in the UK. That's just to give a sense of perspective. So this issue of panic is a very serious part of the way we need to consider this infection. It is also clearly an unpleasant and dangerous disease. It's got a very high mortality, it's got shock, diarrhea, there may be hemorrhage. It's very dangerous to those who look after it. But it is also sometimes portrayed as the worst infection in the world. This would, I think, clearly not be true. I've just compared it to two other diseases I would consider to be worse to catch. Rabies, almost 100% fatal, a terrible death where you die in panic. You die terrified at the end of your life, around 25,000 deaths a year. And tetanus, illustrated here by a very famous painting by Sir Charles Bell, where people have extraordinarily painful spasms, and those who die do so very painfully, estimated to be around 60,000 deaths a year. So I'm just putting this into perspective of other very bad diseases. It's also important to understand its importance even in the West African context. So in Sierra Leone, Liberia, and Guinea, malaria is a much bigger killer of people even now than Ebola in the countries affected. A much bigger killer. And it is likely that when we look back at the end of this epidemic, we will find that more people died of non-Ebola deaths, so things like malaria, meningitis, complications of childbirth, because the health services were destroyed by this disease, than actually died directly of Ebola itself. So this is a second bit of context, I think, that's important when we consider this infection. Now, a little bit about the disease itself before I go on to this particular epidemic. Its natural reservoir is probably bats, and probably more specifically these friendly creatures here, fruit bats, very widely spread over Africa. Most of the time, the main problem they cause is because their poo gets all over your car when you park under a tree. It's, generally speaking, Ebola is passed on within the bat populations without appearing to cause very significant disease. And most infections, and Ebola just happens to be the most important current one, are actually not new in the sense that they're new to biology, but they're new to the species they get into. So new diseases are ones that jump from one species, they jump what's called the species barrier, from one species to another. And some recent examples of importance. HIV itself is a monkey disease. The simian version of it had been around for a long time. It's a sexual disease in monkeys, jumped into humans. New variant CJD, one of the UK's contributions to this. SARS, which is also a zoonotic disease that jumped into humans. And the coronavirus that's currently a small epidemic occurring, for example, in Saudi Arabia at the moment, also a zoonotic disease, probably from either bats, camels, or both. So This thing that actually diseases jump from one species to another is relatively common if you take it over biological time. And generally speaking, when a disease jumps a species barrier, because it's not designed in evolutionary terms for the new species it takes on, it is more dangerous, it tends to kill more of the host, but also less transmissible than its normal host. There are exceptions to that, but in broad terms, that is what you expect to see, and that is indeed what we probably are seeing with Ebola. Ebola is not only a disease of bats and then getting into humans. It can also get into a number of other animals, and of particular importance, it gets into a number of non-human primates, so monkey species, in whom it has a disease very similar to the human disease. And that's quite important for reasons I'll come on to later on in terms of our understanding of the disease. But doesn't appear to be particularly dangerous to its host, at least compared to other animals. So that's the natural history of it. This is the range of the fruit bat family. And importantly, this is the range of the fruit bat family in Africa. And what we've got on this map is up to the current outbreak, all the various outbreaks that have occurred in different places, where the darker the colour, the more outbreaks that have occurred. And as you can see, the majority of the outbreaks have occurred in the central West African belt, in particular DRC and Sudan, and parts of Uganda for Ebola. But in principle, there is no reason why it shouldn't be able to spread if fruit bats genuinely are the reservoir, and I think that seems highly likely, anywhere where the fruit bat range occurs. Until this epidemic, Ebola outbreaks, at least ones have been identified, had not occurred in the 3 countries that we've got it at the moment. And one of the first signs, I think, that we didn't probably pick up quickly enough that something odd was happening was the fact that it was in a country which previously we'd not seen this outbreak, or at least not clinically. There was some serological evidence of previous outbreaks. Now, so far, we've identified 5 different species of Ebola. 4 of which are dangerous to humans, 1 of which does not appear to be. But the probability is actually there are some other ones. I mean, just the likelihood is, so two of these are have been so far proved relatively common by Ebola standards, still quite rare. The Zaire strain, which is causing the current problems, and the Sudan strain. There are 2 other ones that have had very small outbreaks, very limited ones, and there's one, the Western virus, which appears to have no effect on humans. They can go through either a cycle in bats going to animals, which then infect humans, or an internal human cycle. And what we have in the outbreak at the moment is not that bats are infecting humans repeatedly, but it got into one human, got into their family, and has spread from that family through the human population. This is currently a purely human outbreak. Now, something which I think is important to understand for all infections is that there are 2 unrelated things with every infection that you have to consider. One is the virulence, and that is the likelihood that this disease is going to do you serious harm or kill you. And the other is the transmissibility, the ability of an infection, once one person's got it, to be passed on to another. And I'm going to illustrate this with 3 different flu varieties, flu being the biggest infectious threat to the world, both historically and in the future. So you can see how this goes. Starting off with the Spanish influenza outbreak, the H1N1 Spanish influenza outbreak of 1918 to 1920. This was a virulent and transmissible virus. And it infected around 500 million people and killed somewhere between 50 to 100 million people. 100 million people. Some estimates suggesting it managed to kill, in that outbreak, 3 to 5% of the global population. It actually killed more people than the world wars. Then we go on to the Mexican pig flu outbreak, also an H1N1, one of 3 years back, which all of you will clearly remember. That started off, that was highly transmissible. It infected a very large number of people, but it actually was not very virulent. So although it ended up killing up to 200,000 people overall, that was because it had spread so widely. Actually, per person, this was not particularly dangerous. In fact, it was slightly less dangerous than ordinary seasonal influenza. And at the other end of the extreme to that is an influenza, avian influenza H5N1, which so far has got a very high mortality. It is very virulent. If you catch it, you are more than 50% likely to die. But you actually have great difficulty in actually catching it in the first place. You pretty well have to do mouth-to-beat resuscitation on a dying bird actually to catch this virus. So you've got these situations, just taking flu as an example, where you can have very virulent, non-transmissible, very virulent and transmissible, or very virulent and very transmissible, not virulent. Ebola is towards this part of the quadrant. It is a bit more transmissible than avian influenza. It is highly virulent. But it's certainly not, at least at the moment, in these very high transmissible states. Clearly, low transmission, low virulence infections are of no importance. So Ebola is very virulent to humans. It's also, in reality, very difficult to catch unless you are a healthcare worker. Of those who caught it that we know about so far, the mortality rate in the current epidemic looks as if it's around 70%. Previous epidemics have suggested higher mortalities, but that may just be that the numbers were relatively small. But certainly 70% at the moment seems about right. But importantly, you can only catch it by direct contact, either with infected people who've got symptoms, so before they get symptoms, they're not at risk, or with their bodily fluids, so rather like HIV, but additionally diarrhea and vomit. So if I had Ebola at the moment, then everybody, even in the front row, unless I vomited over them, would have zero risk. This is not a dangerous virus in terms of ordinary social interactions if you don't physically touch someone or touch their bodily fluids. And I think that's a very important point for people to understand, and I think it's one of the reasons why, the fact people haven't understood that is one of the reasons that I think there's a lot of the public concern around it, but it's also very important in the way that we think about how we can get on top of this epidemic. Now, a little bit of just the mathematics of transmission, because I'm going to come back to this, because this is the central thing for understanding what we need to do to get on top of this epidemic in terms of public health. The mathematics of transmission are very simple, and they're based on the concept of R, or R naught. Essentially, if R naught is 1, what that means is, on average, one person gives the disease to one person, and the disease is stable. So 10 people this generation of the disease, 10 people next generation is just stable in the population. It's neither going up nor going down. If R naught is less than 1, let's say it's 0.8, then 10 people give it to 8 people, and so on, and that disease is gradually dying out. And if R naught is more than 1, let us say it's 2, to help my maths, then in the first generation you might have 10 people, in the second generation you have 20 people, in the third generation you have 40 people, and so it goes up exponentially. The situation with this outbreak initially was the R naught for this was probably, varying in different places, probably somewhere around about 1.6 in most of the areas we looked at. So it's going up 1.6 times every generation. And in reality, that meant for Sierra Leone and Liberia, early on, and I'll come on to the maths of this, that roughly every 30 days, this disease was doubling. Now, there are 3 possible major routes of transmission once it's got into the human population. So once it's moved from the bats or the non-human reservoir, monkeys in some cases, into the human population. The first, and the one that was discovered most quickly in the outbreak in 1976, is in hospital or from healthcare workers. And that's because as people get the disease, when they initially no symptoms, almost no infectiousness, as they get steadily sicker, they get steadily more infectious, and the time they come into contact with hospitals, doctors and nurses is when they're very sick and they are also very infectious. So the lot of the transmission in the first epidemics occurred in hospitals or from healthcare workers. The second transmission is from burials or the time around death. And this is quite different from many other infections. So, for example, in influenza, most people who've died of influenza are not infectious or minimally infectious after death. That is not true for Ebola. Dead people who've died of Ebola are highly infectious. And if you come on to, and I'll come on to some of the issues around this, if you belong to a society where, as part of the important death burial rituals, touching or washing the body occurs, then this is an extremely dangerous method for passing on the infection. And the third area is in the community between the time someone first gets symptoms and the time when they first are isolated. So they're walking around the community with symptoms, being touched by other people, and they can pass things on. And all three of these are important in the current epidemic that we're facing at the moment. Now, this is how the outbreak actually started. These are the first few cases, and this is from the New England, a study that was published in the New England Journal of Medicine. This was the index case. Passed it on to his family, and then, and this is very classic for Ebola, passed it on to a nurse, to a village midwife, and then it began to spread locally in the population. Now, I'll highlight in a minute all the medical staff who actually were involved in this transmission chain. And what you can see is medical staff are a very key part of this. But I'd also like you to look at the timelines. Really quite a small outbreak between December and March. So up till March of this year, we were dealing with really quite a limited outbreak that was looking pretty similar in the way it was behaving to many other outbreaks of Ebola we previously have seen. And what I've done here is I've just highlighted the points where medical staff were the route of transmission. If we had, for example, an Ebola vaccine that could be given to all medical staff in Africa, this outbreak probably would never have occurred. It would have had the initial cases, and it would have stopped at that point. So protecting healthcare workers is important for many reasons, moral reasons, every possible reason, but it's also important for actually making sure that epidemics don't get out. There was then a serious gap in the global response to this Ebola epidemic. And I don't think anybody, not the WHO, not our chief medical officer, everybody agrees that there was a period between March when we had a small outbreak that was behaving slightly abnormally, and around August, July, August, when this epidemic could probably have been got on top of relatively straightforwardly using conventional means. So there was a delay, and if you're interested in questions and answers, we come on to why that actually occurred. But the fact is there was a delay until around about August of this year, in which time this disease was doubling and doubling again and doubling again. And anybody who understands compounding will understand that means you can move from very small numbers to really very large numbers surprisingly quickly because of the way that actually you're doubling up every generation, or every month at this particular point of the epidemic. So the situation we faced in August of this year, these were the mathematical projections that we did based on, when I say we rather grandly, this is the global community, this is the WHO modelling group, and this is a paper from the England Journal, looking at the three affected countries, plotting out where the various cases had been to date, and where if the existing rate of transmission, that R0 of around about 1.6 continued, where the numbers would have got to by around about now. And as you can see, we're talking about extremely serious numbers, 4,000 in Guinea, 4,000 in Liberia, over 1,000 in Sierra Leone. So at this point of the epidemic, we realised that if we didn't do something about it, this was going to just clock up and up and up. And there was a CDC study that was talking about millions of cases by the middle of next year. So this infection was, at this point of the epidemic, looking very serious indeed. And the probability this would have spread throughout West Africa, if we'd done nothing at this point, was virtually 100%. So a very serious situation faced us. So we don't currently have a vaccine. We don't currently have a specific treatment. So therefore, we had to rely on classical public health methods to deal with this. And remember, this is a very, very dangerous virus to all of those who deal with it, which makes it a much harder thing to deal with than many of the other infections. In essence, what we had to do was very simple. We had to reduce the transmission in hospitals and other healthcare settings. So not just the formal healthcare, but also traditional healers, for example. You might see many people, and some traditional healing methods involve, for example, scarification or taking blood in various things. These would be potentially very dangerous. And some of the big super spreader events early on were from traditional healers. We have to reduce transmission around death and lead to safe burials. We had to reduce transmission in the community by shortening the time between the first symptoms and the point when actually people get isolated. And we had to, and I'm going to go through each of these in much more detail, increase social distancing. So those are the 4 things we had to do. If we could do all of that, R0 of 1.6 is not massively high. So the R0 for malaria, for example, or the equivalent of R0 for malaria in Guinea, in Sierra Leone, would be somewhere between 100 and 300. So this is a much less infectious disease than, for example, malaria in this setting. But we had to get it from 1.6 to below 1. That was our single strategic aim. All other things were secondary. There are many other things we need to do, rebuild health services, improve diagnostic services, and so on. But until we got to the point where the R0 got below 1, till we get to that point, because we have not probably reached it, at least in Sierra Leone, until we get to that point, then all other things have to be secondary, because this will just keep on doubling over some periods of time. So let's go through these various interventions one by one. The first is reducing transmission in hospitals. And here, this is in one sense the easiest because we know what to do. The world leaders in this, Médecins Sans Frontières, MSF, who've done a fantastic job and are one of the real heroes for this outbreak, called it as a serious outbreak much earlier than others, including the WHO, did. We know what to do. A lot of it's to do with good hospital design, making sure that you keep uninfected and infected people apart, unless they're properly kitted up. And then you need to have people in proper protective kit following really rigorous routines where they understand what to do and where it's done absolutely by the book. No one varies it. You just follow the routine. It's very easy to get wrong. Putting this kind of kit on is not that difficult. Working in it, this is waterproof in a very hot climate, is a lot more difficult. This is incredibly, steamy situation. People can get dehydrated, start making mistakes because of that. And taking it off, in particular, is extremely difficult without contaminating yourself. You have to follow really rigid routines. And this is not because it's in Africa, although being in Africa makes it a lot harder because of the climate. As we know from the outbreaks that occurred from healthcare workers in the US and Spain, this can also happen in developed settings. So getting this right is hard, but it is doable. There are routines, and the healthcare workers were, in August, our rough calculations, CDC's and the UK government's, were that on average, at that point, roughly 8 to 10% of healthcare workers per person per year were catching Ebola, and over 70% of them were dying. When you think about those rates, very, very serious risks and very brave people who chose to take them on. But those rates have come right down. They're never going to be taken to zero, but they've come right down because of really good routines. So we know what to do once someone gets into hospital. The second thing we can do is reduce transmission in funerals. And I think as this epidemic has gone by, we have realised quite how major a part of the transmission funerals and the period just before death are. And I think the difficult thing here is not the medical side. The medical side of actually getting a body of someone who got Ebola safely buried is actually relatively straightforward. The difficult thing is doing it in a way which is acceptable to the family, to the community, to the religion, to the people around them. Anybody who's had a funeral of one of their loved ones, of a prominent person in their society, will know it is a very important part of ritual in every society, very important. You have to be able to do this in a way which is safe but also socially acceptable. So you need to actually do a lot of anthropology, you need to talk to religious leaders, and you need to find, if you can, rituals that people can use instead of the ones that they traditionally have used, physically directly washing the body, for example. You might be able to do a ritual washing or a washing of the shroud or something of this sort, but you need to be able to adapt to the local situation. So this is the difficult bit of all of this. And I think two things we have also realised during this epidemic. The first of which is not just burials, but the period just before death that's important. In many societies, the deathbed scene where the people come around to someone who's dying and actually touch them, it's the last thing you do. Any of you who've had a dying relative will know that's what you want to do. This whole period around death, which is the point where people are at their most infectious, is very important. And then we have to remember in particular what loosely are called high charisma individuals. What we mean by that is very prominent members of society, very senior politicians, heads of secret societies. These people have huge burials, which large numbers of people come to. These can be super spreader events. So, for example, recently there was a flare-up where it looks as if around 300 cases occurred from just 3 burials. Because these were very prominent individuals, everybody wanted to come to them. And these are the ones that people are likely to be particularly resistant, actually, to having safe burials, in a sense, imposed on them. I've illustrated this specifically with Dr. Umar Khan, who was Sierra Leone's only virologist and led the early Ebola outbreak. He sadly, along with many other people, many other medical leaders in Sierra Leone, died. The third thing is shortening the interval between the first symptoms, so when people first become infectious, and when they're first isolated. And the difficulty here is that the first symptoms of Ebola, when people first get it, are incredibly non-specific. So most people who get Ebola in the beginning, they have headache, they have fever, they feel generally unwell, they may have slightly bloodshot eyes. This constellation could be lots of things. It could be flu, it could be measles pre the rash, it could be due to malaria, it could be typhoid. Many things present like this early on. So if you isolated absolutely everybody in the countries who had this, you'd have an overwhelmed situation. By the time it's obviously Ebola, it's highly infectious. So you've got to shorten that gap between the time when people first get non-specific symptoms and the time it's obviously Ebola, and isolate them. And one of the methods we've tried to develop, and this is new in this outbreak, is the idea of community care centres, where people come in, you treat their malaria, you treat their typhoid, you treat whatever else they've got without testing them, because the fewer tests you do, you test for Ebola. If they've got Ebola, then you move them to a treatment centre. And if they've not got Ebola, then you send them on their way, saying, look, you haven't got Ebola, you've got malaria, whatever it is, and we've given you treatment. But of course, doing this in a country which has got very few medical staff is difficult. And we're having to do this with untrained people right out in communities. And the difficulty is not teaching people how to give people antimalarials if they've got a fever. That's easy. Any mother knows how to do that for her child in Africa, just as any mother knows how to give paracetamol here in the UK. The difficulty is teaching people not to catch Ebola themselves. That's the hard thing. So we have to be able to do that. We have to do it in a way that's not stigmatising, so that people who go in aren't then shunned by the whole community, and so on. There are very many social issues we need to fix if we're to make these kind of very simple community isolation units work. But this is key to making this period in the community go down. And then finally, we want to do things, it's difficult to catch Ebola, but you want to make it less easy still. So you want to do anything you can to increase what's called social distancing. You don't want to kill off all social activity. For example, these are religious groups getting together to work out a way in which you could do a greeting that is both respectful, but also doesn't involve touching someone. So this is a senior cleric demonstrating one of the local things that's been done on this. And every society has actually done this when it's been faced with an infection. So, for example, social interactions in the UK changed significantly when syphilis arrived in around 1500. Here, people stopped kissing one another on the lips and started moving over to rather more formal handshakes, which are good for syphilis, less good for Ebola. So, this kind of thing, which actually changing social greetings, social interactions, so you reduce physical contact, is something which every society logically does, and the local societies have done that, but obviously we need to help with that. And the key is to find things that are rational, acceptable, and achievable, but keep people as physically as far apart as possible, given that this is only a disease of physical contact. So that's the fourth plank of the strategy. Now, when we started responding properly to this outbreak globally, we were between a rock and a hard place, or between Scylla and Charybdis for the rather highly educated audience that tends to come to Gresham College lectures. The rock was, there is a massive epidemiological advantage to responding very, very fast. And I'll show that mathematically. But when you've got something that's going up, doubling every month, then something, the same interaction now is worth twice the interaction in a month's time. So we really needed to do things quickly. On the other hand, it needed to depend on healthcare workers who, as I say, were dying at a really wholly unacceptable rate. Any rate is unacceptable, but an incredibly high rate in this situation. So throwing healthcare workers into this would have been like throwing untrained First World War soldiers over the top. This is completely unacceptable as a way to do this. So those were the two things that we had to balance between them. To demonstrate why it's important to get speed, I'm just going to take two examples. The first from Nigeria. There was an outbreak in Nigeria that occurred from an individual, and all the ones in blue are healthcare workers. Firstly, demonstrating how dangerous this is to healthcare workers. But this is a very classic mini outbreak you get on top of. Index case came in. They managed to infect a very large number of people because at that stage they didn't know it was Ebola. So they were treated in a number of hospital settings and the people caught it. It then went on to second generation here, but by the third generation, the Nigerian authorities, using established methods, polio control teams and various other people, had found all the people who'd had contact both with this person and with all of these, isolated them, and then the disease dies out. So if you can get on top of the second wave, you often don't pick up the first one. If you kick out the second wave, then you should be able to kill the epidemic off very quickly. This mathematically is what would have happened had there been a delay in Nigeria. This is just modelling out what would have happened. And if the delay had been 50 days, so less than 2 months, we'd have been up to a situation where we'd be talking about between 500 and 1,000 cases. The range could have been anywhere up to 2,500, and the epidemic could have actually taken off very significantly. So speed is absolutely essential. Or this, in a more established epidemic, is how we modelled out, this is Neil Ferguson's work from Imperial College, modelling out the delay by weeks of intervening in Sierra Leone, where the UK at that point still is, was leading the international effort. And every week you delay, each of these graphs is 1 week's delay before you start to act. And so each one of these leads to a higher peak, a longer time before you got control, a higher risk, it'll completely overwhelm you. And there was a serious risk in August of this year that actually our response will be sufficiently slow that actually we would be overwhelmed. By now we'd be talking about tens of thousands of cases, or at least by January or February, and that would be a number that would be beyond our ability to cope. So there was I would say that we had a potentially very, very serious situation we were looking at. It has not completely receded, but I think the risk of completely overwhelming us has reduced in the last 3 months. Now, how has the epidemic played out? Here are the 3 major affected countries. All of these are on the same scale, which is why there's a lot of white here. It's not because I'm trying to demonstrate my Japanese art style. So this is Guinea. I want to make 2 points about Guinea. The first of which is the numbers in Guinea have remained pretty low. And they're still pretty low at the moment compared to the other 2 countries I'll come on to. But the other is there have been already 2 peaks, during each of which we talked about it here and we said, look, we're getting on top of this now. This is now going away. So we can get some false peaks in the epidemic, and I think we need to think about that when we look at the other 2 countries. The second country is Liberia. The US is leading in Liberia. Because Liberia had the biggest problem initially, there was a huge piling in by the very good NGOs, MSF in particular. This is the epidemic as on its way up. This was the point that we were actually looking at in August. That was the graph. So you can see why we were pretty concerned at that point. Huge efforts by international organisations, by Liberians and by others. And the epidemic does appear to be coming down, but I want you to remember that previous Guinea thing. We should not assume that this is gone, this is on its way out and we're just fine. But it does look as if things are improving in Liberia. This is the situation, the most recent data as of last week from the WHO in Sierra Leone, the country where the UK is leading currently. And as you can see, the numbers are now, in terms of known cases, we know that there are probably twice as many cases who are not actually known. But the known cases, we're up at around about 500 to 600 a week at the present time. Now, the graph's not going up exponentially, but it is still going up. Clearly, we hope and expect that over the next couple of months, this graph will level out and start to decrease in the way that the one in Liberia has. But I think we should be clear that at this point of the epidemic, the graph is still going up. Where the Ebola outbreak has, of course, moved around a bit. This was the situation at the end of August, and at that point, the main epicenter was here, very similar to where the first cases had been had occurred in that first family. Going on to now, this is the most recent data on the WHO site. It's moved from here, where there were a lot of cases. That's really gone down because of very good control efforts locally and social distancing. People have responded. But it's now very heavily concentrated in Sierra Leone, around Freetown, in quite near, but not necessarily all in, Monrovia, the capital of Liberia. So the epidemic has moved, and it's begun to concentrate in the urban areas. And this is not that surprising, actually. For getting social distancing right is easier in rural areas than it is in urban areas. What are the chances of this epidemic spreading? Well, first of all, what are the chances of it spreading in Africa? At this point in time, I think that there remains a significant chance there will be further outbreaks of Ebola in other countries in West Africa. It's already had outbreaks in Nigeria, Mali, and Senegal, but all of them have been contained by the local authorities with assistance from WHO. And the standard thing which has happened with these, and also with the epidemic that occurred in America, is that you have an imported case. People may not recognise it's Ebola initially. Then you have some secondary cases from that imported case. But then by that stage, people have recognised it, and the isolation, the active isolation starts. And by the third generation, it comes right down, and then it stops. That's what's happened in all the previous outbreaks. Our worry, of course, is it might get into the relatively ungoverned spaces. There are bits of West Africa where, if you read the news, you'll be aware of the fact that the government is not fully in control and where the health services are extraordinarily weak. And if it got into one of these areas, then we could have further epidemics of quite significant impact, and they could be very difficult to control. Imagine if it got into an area, for example, where Boko Haram have a lot of activity. That would be a very serious global issue. How about the UK? You'll all have seen a lot of headlines on this. Our Chief Medical Officer has said very scientifically, and I think this is probably as good a scientific answer as you can get, we will probably have a handful of cases. That's likely. We have a Sierra Leonean diaspora, we have healthcare workers who are going to Sierra Leone, we have people who are involved in commerce of Sierra Leone, palm, oil, mining, a variety of other very important economic activities. So we probably will see a few cases. Some of them will know they're Ebola on the way in, but some of them we may not. There is the potential for secondary cases. So the first case leading to some secondary cases, including to healthcare workers, who are the people who are most likely to come into contact with them when they're very sick, as happened in Nigeria. Once they're identified, they will go into the Royal Free Centre. This is the setup. Once they're inside that setup, that's incredibly safe for those working around them. Not 100%, you can still make mistakes, but nevertheless, it's, once we actually got identified cases, the risk of transmission is very low. There could be a small third wave, incredibly unlikely, but given the efficiency of Public Health England and the equivalent in the devolved authorities, fourth generation. So we are all confident of our ability not to stop all Ebola coming in, that we can't stop, but to stop Ebola getting into a propagated epidemic. We are completely confident that that can be achieved in the UK. So effectively, our view is the chance of a significant propagated epidemic is zero. A few final points before I just leave a bit of time for questions. I'm frequently asked, could this mutate to become more infectious? It's not very infectious now. Could it become more infectious in due course? And the answer, of course, is that if we left it long enough, that is the most likely evolutionary outcome. Infections often attenuate. They become less severe as time goes by, but they also tend to become more transmissible because that's what natural selection would make them do. That is just natural selection as Darwin laid out, and it happens in multiple infections. For example, HIV, if you read the newspapers in the last couple of weeks, looks as if it's becoming a bit more, less virulent at the moment, may possibly be becoming more infectious, difficult to tell. Very unlikely to be fast, however, and it's exceptionally unlikely, and this is an important point, to change its mode of transmission. HIV is a sexual infection in monkeys, it's a sexual infection in humans. By and large, infections can become more transmissible, but they relatively rarely, if ever, change their mode of transmission. So we do not anticipate that Ebola is likely to become an airborne infection. It certainly is not an airborne infection at the moment. How about Ebola vaccines? Currently, and I'm talking about the state of knowledge, every week that goes by we're getting more information. There are 3 in early or near early clinical trials. These are the safety and immunogenicity trials. 2 of them are relatively similar to biologically. They're in chimpanzeeviruses, non-propagating virus in humans, but it's a way of getting the material into humans. One of them is a slightly different live virus construct, MVA. 2 of these would require, probably, for good protection, a first vaccination, and a boost, weeks to possibly months later. That's fine if you're talking about, obviously, protecting people for the long run. That may be more difficult in an emergency situation, and we're still working that through. One of them may only require just 1 shot, but also it's likely to have greater side effects. So you're having to trade off side effects against speed of action, possibly. That's where we are at the moment. This may change. There's a serious attempt globally to try and fast-track these much faster than almost any vaccines, if any vaccines, have been developed before. WHO, our own government, put a lot of time into this to try and improve this. But even if this goes well, it's fairly unlikely that we'll have vaccines that are deployable until the later part of next year. For the general population, there will probably be for some special groups. We're also hoping to test out multiple new approaches to therapy so that the 70% mortality can come down significantly. The thing which we can do immediately, obviously, is improve fluid management. That's something which we've actually, clearly we could do better on. These are some people who've recovered from Ebola, including Will Pooley, the very brave nurse from the UK, and the possibility of them donating blood or plasma that have antibodies in it and could help people is there, and we're testing. That's something which people want to try out. Artificial antibodies grown in GM tobacco, ZMapp, which got a lot of coverage early on, is another possibility. Various antiviral drugs theoretically look as if they might work in Ebola. So all of these need testing, because what we all know from medicine is many things that look as if they should work don't when you test them properly. So these all need testing properly. And there are many other ideas, some of which are wholly mad, and some of which look as if they're mad, but are probably very sensible. So there's a lot of different approaches to this. The WHO has a prioritised list, and we're trying to work through that. And of course, we're trying to improve safer and more rapid tests. So what are the scenarios for the next 6 months? Well, I think that there are essentially 3 broadly. The first is that it spirals out of control. We think, whereas in the beginning of August, that was a reasonable thing for us to worry about, I think now the chances of that are very low, not 0. The second is that in the next few months, we get a complete interruption of transmission in all 3 countries. There are no other outbreaks. That is possible, but we think it is relatively unlikely in that time frame. The most likely is we'll have an intermediate outcome. We'll control Ebola in most places, most of those areas on the map, but there will be some hotspots and mini outbreaks will occur in a variety of places, including potentially in places that aren't currently infected. And then we have to grind out a victory over many months in small incremental steps. That is the most likely outcome, I think most people who look at this consider. We can't eradicate Ebola because there's an animal reservoir. It's one of the key criteria for eradicating diseases. There must be no animal reservoir. There is one, therefore we can't. But we can eliminate this outbreak, and indeed we must do so because of the enormous impact it's having on the countries, the health services, and the individuals who catch it. Before I finish, I should just pay tribute to the multiple groups from the UK who have volunteered or have worked together to get on top of this epidemic, primarily in Sierra Leone, but also in other countries as well. Many NGOs, academic groups, the NHS, many volunteers, Wellcome Trust, MRC and others, and many individual doctors, nurses and public servants, both military and civil service, who volunteered to go out there and do this on behalf of all of us. They will be working 7 days a week, all the way through the Christmas period to get on top of this for the world. And I think we owe them a great debt of gratitude. The governments, departments that are involved in the UK have also worked together incredibly seriously on this, and I think the UK has taken a really major lead on this. And I think it's something we should take pride in, whilst accepting that the job is very far from done. So, in summary, Ebola remains a clear and present danger. I would argue pretty clearly that between March last year and July this year, most people would agree the world reacted too slowly to this epidemic. But there's now an impressive global outbreak. It looks as if the worst is over in Liberia, but in Sierra Leone we've still convincingly to see a peak, although I'm confident the one will come. Eliminating this outbreak will take time. It's fallen off the news headlines, but I do not think we will probably have seen the end of this in the first half of next year. We may do towards the second half if we're lucky. We can guarantee that outbreaks of Ebola will happen again because there's an animal reservoir. We can guarantee that. But if we do this right, we are currently experiencing the worst Ebola outbreak in history, both past and future. Thank you very much.